Good evening, everyone. Myself, Dr. Veena Venkatesh, working at Ajanta Pharma Limited as General Manager, Medical Services. On the behalf of Ajanta Pharma, I take the privilege of welcoming doctors from all over India to this webinar. Ajanta Pharma is one of the top pharma companies in cardiology segment and focused on bringing innovative formulations for the first time in India. We thank our doctors for the association with us. Today's scientific sessions would be blood pressure control in 2020 and latest guidelines applicable to India for combination therapy. For this session, we are extremely privileged to have Padmashri Dr. C. Venkataram, a global legend in the field of hypertension, as a speaker. We are also honored to have Padmashri Dr. S.C. Manchanda as the chairperson. Also, we have highly respected panelists, Dr. S.N. Narasingan and Dr. Narsingh Verma. To give a brief introduction of our chairperson, Padmashri Dr. S.C. Manchanda, he is a senior consultant at Sir Gangaram Hospital, New Delhi, and was the past HOD of cardiology at AIIMS. The speaker, Padmashri Dr. C. Venkataraman, is a director of Apollo Institute for Blood Pressure Management, Apollo Blood Pressure Clinic, Hyderabad. And the panelist, Dr. S.N. Narasingan, is a fellow of Royal College of Physicians and American College of Chest Physicians and Indian College of Physicians. And Dr. Narsingh Verma is a professor of KGMU, Lucknow. He is president, Asia Pacific Society of Hypertension. With this brief introduction of all the speakers and the chairperson, I would like to hand over the session to Dr. Manchanda. And the delegates, you can please put your questions in the chat box and will be taken up during the panel discussion. Thank you. So over to you, Manchanda.
Thank you. It's indeed a great honor to chair a webinar on hypertension treatment 2020, addressed by none other than Dr. Venkatram, in the presence of two leading personalities, two leading clinicians of the country, Dr. Narsingha and Dr. Verma. As we have already heard, Dr. Venkatram is one of the leading global authorities on hypertension. He has devoted his whole life on the prevention, management, and treatment of hypertension. I would like to call him the living legion in hypertension medicine in India. Before I invite him to give his talk, which will be extremely good, I'm sure, because he has a very clear concept of hypertension, I would like to make a few comments as a senior cardiologist. I have been in practice of medicine for the last about 55 years, before many of you might not have been born. And I have been seeing patients of hypertension from that time. I have seen spectacular advances in the pharmacology of the treatment of hypertension since 1955, for the last 50 years. 50 years back when I started my practice, we had no treatment actually. We had only reserpine, which was an extract of Royalfia, and maybe a few diuretics which are on heavy dosages. Then I have seen the development of beta blockers, which came with a bang. Of course, they have very little importance these days in the management of hypertension. Then calcium channel blockers, ACE inhibitors, and ARBs. These are such spectacular advances that it is possible to control blood pressure in any patient of hypertension if they are used judiciously. However, the blood pressure is not controlled in majority of the patients, in spite of all these advances in the pharmacotherapy that we know of. And actually the condition in developing countries is very poor. According to one study, the pure study, the urban and rural population, the proper control of blood pressure was in very small number of patients, so less than 10% in the rural population and maybe 25% in the urban population. Now, what is the reason why the compliance is so poor? It may be because of ignorance. It may be because of the cost of the drugs. It may be because multiple drugs have to be taken. most of the hypertensions need more than one drug. And finally, it could be the side effects of the drugs. The compliance is really poor. We can have no better person than Dr. Venkat, who is an authority in the field of hypertension, both in United States and in India, to tell us how to manage the patients of hypertension adequately in the present times. So it's a great pleasure to invite Dr. Venkatram to give his address on BP control in 2020. Dr. Venkatram, please.
Yeah. Thank you very much, Dr. Manchanda, and my greetings and best wishes to all of you who might have tuned in. At the outset, I want to mention a few remarkable things about this evening's program. I think this evening's program is probably the first program to be conducted on hypertension since the release of the International Society of Hypertension guidelines day before yesterday. So less than 48 hours, we were able to discuss this topic that has been widely disseminated in the last 48 hours. So that is number one. Number two, an important thing is Dr. Narsingan, the president of Indian Society of Hypertension, was one of the reviewers of this document. Very few people were given an option to review guidelines. Not many people can review, and they don't want too many reviewers also. So we're glad from India, on behalf of the Indian Society of Hypertension, Dr. Narsingan was chosen to review, so that is another first. And the other first is Dr. Narsingh Verma, who has done a lot of work on chronobiology of hypertension, chronobiology of the heart rate. And this particular document that was released 48 hours ago makes a mention of the importance of controlling 24-hour blood pressure effectively without causing an increase in heart rate. So ladies and gentlemen, so we have these almost novel first things that is happening in India. And I should be remiss in not acknowledging our own chairman, who has seen the whole plethora and landscape of development of antihypertensive drugs, starting with reserpine to the current area. So this is not just one more webinar. This is not one more CME. This has got a number of first things that we're able to share with our colleagues in India. So let me start with the first slide, and I'm going to do the screen share, and we'll go from there. As you will see on the screen, that we are going to discuss for next few minutes on the rationale and importance of triple combination for blood pressure control. All of us are familiar with dual combination therapy, but what has come into vogue is triple combination therapy. About 5 years ago, if I had mentioned triple combination therapy, many of us would have been a little bit more skeptical or careful whether we can cause significant hypotension. But the experience has shown that triple drug combination therapy as a fixed dose does not cause hypotension any more than a single drug or double combination. So one thing that we have gained in the last 5 years is on confidence on using triple drug combination to control the blood pressure. As Dr. Manchanda has clearly mentioned in his opening remarks, that in India, cardiovascular disease is the main reason for premature morbidity and mortality. And these are the data from India that on an annual basis, we almost spend $20 billion to take care of patients who have hypertension and comorbidities. And that translates to less than $1.5 billion monthly to manage people who have cardiovascular disease. Huge financial expenditure in the country. And again, hypertension is the leading cause of mortality from cardiovascular disease and from stroke in India, very common. And this is a slide which is almost 100 years old. It's almost 100 years old, shows that if your blood pressure 100 years ago was 120 or 80, your survival was very good. But if you increase the blood pressure slightly, I'm talking about 100 years back, the life expectancy is reduced by 4 years. And if you increase the blood pressure a little bit more, the life expectancy is decreased by 8 years. And if you increase it further, the life expectancy is decreased by 16 years. So ladies and gentlemen, the story of hypertension has come back full circle. What we were told 100 years ago, the ideal blood pressure is 120 or 80. We are talking about now in 2020, the ideal blood pressure should be 120 or 80. And any increase in blood pressure that is not controlled reduces life expectancy. Now, what happens in this slide is that in a community setting, even if you reduce the blood pressure slightly, a little bit reduction in blood pressure causes a significant reduction in mortality and morbidity. For example, if you reduce the blood pressure by 2 millimeters of mercury, systolic 2 millimeters of mercury, that translates to reducing the blood pressure annually by 550,000 millimeters of mercury. So if you reduce the blood pressure by 3 millimeters, ladies and gentlemen, that translates to an annual reduction in that particular patient of blood pressure of nearly 16 lakh millimeters of mercury. So what I'm trying to tell you is, although numbers 2 and 3 look very benign and innocuous, when you convert it to an annual increase in blood pressure, it comes to a significant increase in the burden on cardiovascular system as a result of high blood pressure. The reason why we treat hypertension is shown on this slide. Number one, hypertension can cause so-called acute complications such as hypertensive encephalopathy, left ventricular failure, intracerebral hemorrhage, etc. But that is not the reason why you're treating hypertension. Ladies and gentlemen, the reason why we're treating hypertension is to reduce coronary artery disease, peripheral vascular disease, cerebrovascular disease, chronic kidney disease, and systemic aortic atherosclerosis. So ladies and gentlemen, the reason why we're treating hypertension is to prevent so-called chronic disease burden as a result of involvement of the heart, peripheral blood vessels, cerebral blood vessels, and chronic kidney disease and systemic atherosclerosis. Dr. Manchanda is going to comment later on an area of his expertise and research and his contribution to so-called lifestyle changes in the treatment of hypertension. Lifestyle changes in the treatment of hypertension should always be the common denominator. In terms of diabetes, hypertension, hyperlipidemia, obesity, metabolic syndrome, lifestyle changes are always the initial step in the treatment of hypertension. And this is going to be addressed by Dr. Manchanda, and he's also going to provide the latest guidance we're getting in terms of non-pharmacological treatment. In terms of the pharmacological treatment, we have a number of drugs that are used, diuretics, beta blockers, RAS blockers, CCBs, aldosterone antagonists, all of them. They're quite effective in the treatment of hypertension and the prevention of complications. But the thing is, they're most effective when you give them as combination therapy, not as monotherapy. The reason why combination therapy is strongly recommended, in fact, we should only talk about combination therapy, not about monotherapy. I had written to the DCGI, FDA in India 3 years ago, that they should not approve single molecules anymore for hypertension, but they should approve the combination molecules. Hypertension is a multifactorial disorder, and the multiple mechanisms participate in the pathogenesis of hypertension shown on this slide. You see there are several interdigitating mechanisms that are responsible for increasing the blood pressure. If you use only a single drug, you block one mechanism, but other mechanisms are left open. In fact, the other mechanisms overcompensate when you block one mechanism. That is the reason why you must block multiple mechanisms in order to achieve the blood pressure control. it is, it is like a thief who is in a room and there are 4 doors that are open. If you block one door, the thief can escape from other 3 doors. Similarly, in the treatment of hypertension, you must block all the outlets that could increase the blood pressure. And that is the reason one should advocate dual drug or triple drug combination so that you offset all the mechanisms that are responsible for increasing the blood pressure. All the guidelines, including the guidelines released day before yesterday, they all suggest that initiate drug treatment of hypertension with combination therapy and not as monotherapy. And we in India should be the advocates for this pharmacological principle. But this pharmacological principle is not a new phenomenon. It has been known it has been known since the time of Dr. Rustum Jal Vakil, who is the father of pharmacotherapy of hypertension, not just in India, in the world. He was the one who wrote a combination of reserpine with hydralazine and with a diuretic, reduces the blood pressure, and he has shown phenomenally that one could treat malignant hypertension with combination therapy long time back. But anyway, the British Hypertension Society almost 30 years ago has again recommended that one should use combination therapy or monotherapy. The reason I'm saying it, this is not a new concept. The concept has been there for a long time. The only thing that is new is the components of the combination have changed. In the olden times, we used to use drugs that cause side effects, but now we're using components which are easily tolerated and do not cause too many side effects. The importance of combination therapy is well known to you, that combination therapy not only reduces cardiovascular and renal complications, but we hope that the patient compliance with fixed dose combination is much better compared to taking multiple medications at the same time. This is a slide which shows that the best compliance for a chronic disorder such as hypertension is when you give a single drug or fixed dose combination. Once you start giving 2, 3, 4, 5, 6, 7 drugs, then the compliance reduces because nobody really would like to take patients so many drugs. Even people in the medical profession, they don't like to take multiple drugs in a given day. So it has been shown that fixed dose combination compliance is the highest. This is a study that was done again long time back, looking at the compliance of fixed dose combination, or you give the same components individually as free drugs. And as shown on this slide, when you give fixed dose combination, the compliance is much, much better than giving the same components separately. Now, the importance of compliance is shown on this slide. If patients discontinue antihypertensive therapy, there is a 15% increase in the risk of acute myocardial infarction within 2 years. And there is a 28% increase in the risk of stroke within 2 years. So ladies and gentlemen, if your patients stop antihypertensive drugs, within 24 months, they're at a high risk of acute myocardial infarction and they're at a high risk of acute stroke. So compliance is very, very important to prevent cardiovascular complications. Every trial that was done in the last 40 years has always used combination therapy. They did not use fixed dose combination, but they used combination of multiple drugs, 2 drugs, 3 drugs, etc. But now we have fixed dose combination, so we can apply what has been shown in clinical trials of combination therapy, but take advantage of so-called fixed dose combination. This is an interesting study that shows that when you double the dose of a single drug, you don't get that much mileage. Even let us say you're taking a beta blocker or a RAS blocker or a diuretic or CCB, doesn't matter. If you double the dose, you don't get incremental benefit. But if you give combination therapy, keeping the same dosage, you get a tremendous increase in terms of the response. So pharmacological principle is doubling the dose, you don't get double benefits. You get double side effects. But when you use combination therapy, you get incremental benefit and decremental side effects. Very, very important. And this is just a demonstration when you combine a diuretic, let us say with an angiotensin receptor blocker, you get a greater effect than giving these drugs as monotherapy. And this is true for all monotherapies. When you give them, you get some effect. It's not zero, you get some effect, but the additive effect is seen only in combination. And the other thing about combination therapy is the side effects that you get from a single drug are neutralized by the other component of combination. So this is a trial showing that you can get hypokalemia with a diuretic used as monotherapy. But if you use the same diuretic in combination with other drug, in this case a RAS blocker, the side effects are significantly reduced. So another benefit of combination therapy is neutralization of side effects that you get from monotherapy. So you get additive effect on blood pressure, and you also have a neutralization, offsetting, attenuation of side effects from monotherapy. This is a slide showing that when you start the patient on combination therapy, dual drug combination therapy, you get a very good effect on blood pressure. But if you change the patient to triple drug therapy, you get further reduction in blood pressure. So dual drug combination is beneficial, but the maximum benefit you get in terms of blood pressure is when you use triple combination. That is what is shown on that white color in this slide. This is actually data from India. Data from India have shown that when you give 3 drugs separately, the compliance rate is very low. But when you give same 3 drugs as fixed dose combination in the extreme right, the compliance is very high. And these are the data from our own country, again suggesting our patients tend to take combination therapy as fixed dose combination, but not as separate medications or compliance. There is one more advantage of combination therapy. You reduce the blood pressure very quickly. Very quickly, I don't mean in matter of few hours, but you reduce the blood pressure within few days or few weeks. And the studies have shown once you reduce the blood pressure rapidly, within few days or few weeks, you further decrease the cardiovascular mortality. So one more benefit of combination therapy is you achieve the goal blood pressure much sooner, much rapidly. And when you do that, you reduce the complication rate. Sometimes people get a little bit panicky and they get very nervous when I use the word rapidly. I'm not saying in few hours or few minutes. I'm talking about in clinical setting, few days, few weeks, you reduce the blood pressure. The rapidly you reduce the blood pressure, greater is the benefit. This is from a study called Value, and it shows that when people who have responded within 6 months, shown as immediate responders, they had a greater benefit in terms of cardiovascular complications and survival compared to those who achieved the goal after 6 months. So the take-home message is, ladies and gentlemen, if you want to achieve the blood pressure, you should try to achieve it within 3 to 6 months, but don't wait for too long, because if you wait too long, the patient is exposed to longer duration of hypertension. But if you achieve the blood pressure quicker, the patient is exposed to longer duration of normotension. That is very, very important. Now, what happens if you reduce the blood pressure with triple drug combination in Indian setting? And these are the data from Indian setting. You will notice day 0 is when the patients are not on any drugs. Visit 2 or day 15 is on triple drug combination. When you give triple drug combination, not only you achieve it quickly, but it is maintained for 30 days and 90 days and 180 days. So this is a study from India showing that triple drug combination, you bring the blood pressure very nicely immediately, but it is maintained as long as the patient takes the medication for 3 to 6 months of treatment. Very, very important contribution from India that we can achieve blood pressure level quickly, and that can be maintained as long as the patient is compliant with the treatment. Now, let me talk for a few minutes on the components of combination therapy. I mentioned to you the components of combination therapy have changed since the time of Serapis. Serapis was the first triple drug combination introduced in India to the entire world. And the combination of Serapis was, as Dr. Manchanda alluded to, reserpine, hydralazine, and hydrochlorothiazide. But these components are not well tolerated. And therefore, the concept of triple drug combination fell into disrepute, not because it was bad, but because of the components of the combination. Now we can reclaim the triple drug combination by changing the players, by changing the components. Currently, we can use, in terms of initial therapy, ROS blocker plus beta blocker, or a CCB plus a diuretic, or a CCB plus a diuretic or a beta blocker, or a beta blocker plus diuretic as initial therapy. And triple combination can be any of these. The above can be used in a triple drug combination. So let us now address the one combination therapy which has got a ROS blocker and a beta blocker and a diuretic. And I want to mention one thing about triple drug combination, which is very germane to India. To my knowledge, India is the only country where a triple drug combination includes a
voice. No sound.
Yes, sir.
Audio stop. Audio stop.
Let's come back.
Are we back?
Yes, sir, you may continue.
So you are on mute. Can you remove the mute?
I was speaking before.
Unmute, sir, unmute.
If you could repeat the step 2, sir, again.
Okay, I'm not on mute now. I have not.
You're
been-
clear. Clear.
Okay. The step 2, if the above therapy is not useful, then you go to triple drug combination. Not able to advance the slide now. Okay, these are the components of the triple combination that we're going to address. One is a beta blocker. Example would be metoprolol, cardioselective beta blocker. And other is telmisartan, which is a so-called double acting angiotensin receptor blocker. And other is chlorthalidone, which is a long-acting diuretic. All these drugs have been shown to be quite effective. All these components have been shown to be quite safe. They're well tolerated, and their outcome trials with all of these drugs, their outcome trials. By the way, before I forget, as Dr. Narasimhan might comment, in the newer guidelines, they suggested that one should use a thiazide diuretic only if the thiazide-like diuretics are not available. So keep that in mind. So with metoprolol as a cardioselective beta blocker, ladies and gentlemen, We have a number of outcome trials which are positive. With angiotensin receptor blocker, which is a dual acting angiotensin receptor blocker, telmisartan, you have those outcome trials. And with chlorthalidone, you have those outcome trials. And I'm going to discuss these outcome trials very, very quickly. And this is one of the earlier studies done many years ago, hypertension detection follow-up program, showing that patients who received chlorthalidone, they had a reduced mortality compared to those who did not. And this is another trial called systolic hypertension, the elderly program, where patients who received chlorthalidone over the age of 60, they had a reduction in the stroke by 40% compared to those who did not. In the multiple risk factor intervention trial, there was a greater fall in blood pressure with chlorthalidone compared to hydrochlorothiazide. So these are the outcome trials with chlorthalidone. And chlorthalidone was shown in the HALT trial to reduce the risk of congestive heart failure significantly compared to other drugs that were used in the trial. And compared to hydrochlorothiazide, chlorthalidone reduces the nighttime blood pressure, and Dr. Narsingh Verma will comment on the importance of reducing the nighttime blood pressure later on. So ladies and gentlemen, what I have done in the last 3 minutes, I have shown you the outcome trials with chlorthalidone, starting with HDFP, Mr. Fett, SHEP, etc. Now let us talk about the RAS blockers. Example would be telmisartan. And angiotensin, as you know, can cause a variety of cardiovascular consequences over and beyond increasing the blood pressure. And that was the reason for developing RAS blockers. You not only reduce the blood pressure, you also minimize the target organ damage that is mediated by angiotensin. I mentioned to you that telmisartan is a dual acting angiotensin receptor blocker. Not only it blocks the angiotensin receptor, that is why it is called angiotensin receptor blocker, but it also stimulates PPAR gamma, which is a metabolic pathway. When you stimulate PPAR gamma, you actually have an effect that is favorable on lipids, insulin, and cell inflammation. So the bifunctional ARBs exemplified by telmisartan, they not only block the angiotensin receptor and reduce the blood pressure, but they also improve the metabolic parameters by stimulating PPAR gamma. That is the reason why it is called bifunctional or dual-acting angiotensin receptor blocker. And this is one outcome trial known as On Target, which has shown that telmisartan is as effective as an ACE inhibitor ramipril, and the combination is also useful in reducing cardiovascular complications. So an outcome trial with telmisartan. And telmisartan is a long-acting angiotensin receptor compared to losartan or valsartan. It's a long-acting drug, and it reduces the blood pressure for 24 hours with once-a-day administration. We're not going to talk about central aortic blood pressure that much, but this is an area of a lot of interest. And among all the ARBs, telmisartan has been shown to reduce the central aortic blood pressure, probably by blocking angiotensin, but maybe also through PPAR gamma, we do not know. Now, I have shown you the outcome trials with telmisartan. Now, let me show you the outcome trials with beta blockers. So ladies and gentlemen, what I'm showing is I am going through a cascade of information that not only the mechanism of action, but also the outcome trials that are attached to each molecule so that we can understand the rationale of combining the three molecules. It has been shown many years ago that atenolol is no better than placebo, but in fact, compared to placebo, atenolol can be harmful because due to unopposed alpha-mediated vasoconstriction. So the controversy about beta blockers is only related to atenolol, but there's no controversy related to metoprolol, celiprolol, nebivolol, etc., or bisoprolol. There's no controversy. So I just want to make it very clear. When you hear the word beta blocker controversy, it is really atenolol controversy, but should not be applied to other beta blockers. In fact, studies have shown beta blockers are extremely useful in reducing cardiovascular risk. And this is a study showing that beta blockers, both in younger and older individuals compared to placebo, reduce the cardiovascular risk. And this is one of the first trials conducted with metoprolol for outcome called MAPI. You will notice when metoprolol, shown in the yellow color, was compared to thiazide diuretic, there was a significant decrease in sudden cardiac death as well as total mortality. The first outcome trial with a metoprolol showing a reduction in mortality and morbidity. And this is a composite slide showing the effects of metoprolol on primary prevention, which is what I have shown earlier. Secondary prevention, also recurrent MI, recurrent strokes have been shown to be reduced with metoprolol, secondary prevention. And in terms of the heart failure prevention, so-called MERIT heart failure trial has shown that metoprolol reduces so-called new onset and progressive heart failure. So this is a very beautiful slide showing that metoprolol has been shown to decrease the risk of sudden death in primary prevention, in secondary prevention, and also in tertiary prevention. And interestingly, unlike atenolol, beta blockers has been shown to reduce atherosclerosis. And this is a study in human beings using metoprolol and looking at intima media thickness. You will notice in comparison to placebo, chronic use of metoprolol has been shown to decrease intima media thickness, we presume is decrease in atherosclerosis. What they have shown is when intima media thickness was reduced, there was a significant decrease in mortality, suggesting metoprolol has so-called anti-atherosclerotic effect in human beings by mechanisms we do not know. It reduces intima media thickness, and therefore it also reduces cardiovascular complications. And this is so another study which I mentioned earlier, MERIT heart failure, which has shown long-term use of metoprolol was shown to decrease cardiovascular mortality as a tertiary prevention. So ladies and gentlemen, what I have shown so far, let us pause for a minute. I have shown you the outcome trials with chlorthalidone. I have shown you the outcome trials with telmisartan. I have shown you the outcome trials with the beta blocker. And these three components are used in the combination. And I'm actually guiding you towards so-called evidence-based medicine, which you connect molecule to the outcome trials. And this is a trial that was done in US many years ago, antihypertensive response to an angiotensin receptor blocker. And when you added a beta blocker, metoprolol, there was a further reduction in blood pressure. Now I'm showing you some clinical data, and this was in diabetic patients. And this is a trial which showed the baseline blood pressure and the antihypertensive response to metoprolol, and when you combine it with chlorthalidone. So I'm again showing you the clinical data on how combination therapy reduces the blood pressure. And this is a trial that was actually done in India. I'm showing you a lot of Indian data, which are very important. This is a trial that was done in India, looking at antihypertensive response to a combination of metoprolol and low-dose chlorthalidone, suggesting that in the Indian patients, the effects are as good or as effective as shown in other studies. And this is a trial looking at the combination of telmisartan in combination with hydrochlorothiazide or telmisartan in combination with chlorthalidone. By the way, this is also an Indian study. And you will notice that when telmisartan was combined with chlorthalidone, there was a greater fall in blood pressure in comparison with hydrochlorothiazide. Again, I'm showing a network of the theme on why these three components that we're talking about are combined in this triple combination based upon the clinical data from abroad and substantiated from India also. So, Mr. Chairman and ladies and gentlemen, in conclusion then, the combination of metoprolol reduces target organ damage, telmisartan reduces target organ damage, chlorthalidone reduces target organ damage. When you combine them, you actually have a comprehensive or a holistic reduction in target organ damage. So this is how the scenario is. You have a lock, namely hypertension, out of control. Then you have several keys here. All of keys, they look the same, but there is only one key that could unlock. And that is the key that you have to choose, namely combination therapy. And which components of combination you want to use, it is up to your clinical judgment, based upon your level of comfort, based upon your level of knowledge, and based upon your understanding of the subject. The idea of showing this slide is we have to unlock the mystery of uncontrolled hypertension by finding the right key. When you use the right key, it unlocks. But if you keep on trying a different key in a blind fashion, you're losing time of weeks and months and weeks and months, and that doesn't help. Remember, I showed you that if you reduce the blood pressure within 3 to 6 months, your outcome is much better than reducing the blood pressure later on. It is very important, therefore, not to lose valuable time. And you find the right key and you unlock the mystery of hypertension. In terms of the pharmacology, Dr. Manchanda and the panelists comment, metoprolol is generally considered as a beta blocker plus because of cardioselectivity. Telmisartan is considered as ERB plus because of its PPAR gamma effect. Chlorthalidone is considered a diuretic plus because it is long-acting duration, and it also may have an effect on pleiotropic effects in the kidney, such as nitric oxide and platelet aggregation, etc. So it is called a diuretic plus. So these are three components which are basically a beta blocker, but you have added something. Basically ARB, you have added something. Basically a diuretic, you have added something. So ladies and gentlemen, when you give a beta blocker, the blood pressure goes down. When you give ARB, the blood pressure goes down. When you give a diuretic, the blood pressure goes down. When you combine them, you have so-called additive effect on the blood pressure. That means when you give a combination, the fall in blood pressure is greater than you get with components. And this is something that I have drawn last week. You can give drug A ARB, drug B, a beta blocker, drug C, chlorthalidone. They're quite effective. When you combine them, so-called ABCs, the efficacy is greater. And this is what is known as a geometric reduction in blood pressure. This is called pharmacological synergy, resulting in additive blood pressure fall when you combine them. So the combination therapy in 2020 is safe, effective, and well tolerated. Blood pressure response is a little bit more predictable compared to monotherapy. And most importantly, the blood pressure response occurs in a timely manner. You don't have to wait for too long. It occurs, and I have shown you outcome data, because every time the question comes out, Dr. Ram, what are the outcomes? What are the outcomes? I have shown you the outcome data, and I have also shown you the Indian data. So among the ARBs, at least in India, telmisartan appears to be the gold standard. Among the beta blockers, at least in India, metoprolol appears to be the gold standard. Among diuretics, chlorthalidone is coming up due to the recent guidelines. So when you give triple dose combination, you have triple benefits of reducing morbidity and mortality. And ultimately, it is a win-win situation for the patient and their families. So ladies and gentlemen, I am showing the same slide that we started with. You have combinations of initial therapy, and now you have a triple drug combination. You can combine the above. So multiple risk factors patients might have. The blood vessel is healthy. When they develop hypertensive disease, the blood vessel is atherosclerotic. And when they develop an event, such as an MI or CKD or stroke, they have vascular occlusion. So the best time to treat is the patient has risk factors only and not vascular disease, and the blood vessel is still healthy. So in the time that I had within last 30-35 minutes, I have provided you the rationale and importance of triple drug combination for blood pressure control in India. The way I have done it is I have pointed out to the guidelines. I have shown you the Indian scenario. I showed you the pharmacological basis of selecting these drugs Importantly, I was able to cull from the literature the Indian data and also the outcome trials. So based upon there appears to be a scientific basis of applying triple drug combination to achieve blood pressure control in India and to decrease morbidity and mortality, that $1.5 billion per month we spend on cardiovascular disease can be significantly reduced by preventing these cardiovascular complications. So I hope that I have given you some food for thought, and with whatever explanation was possible, I was able to provide them for your consideration. So Dr. Manchanda, Ms. panelists, ladies and gentlemen, will conclude. Thank you very much for your attention.
Thank you, Dr. Venkatram, for your outstanding talk as usual, and telling us the evidence why we should use triple therapy in patients with hypertension. Am I audible?
Yes, sir. Yes, sir.
Yes.
I think the message is very loud and clear that you have given based on the evidence that every patient should have multiple drugs in one combination, and triple therapy seems to be the best because the compliance is greater. You said very well, the side effects are much less and the fall of blood pressure is also much greater. And you have given us a lot of evidence why this combination, these three drugs is extremely good. You mentioned about lifestyle, and if I can take a minute before I go to the panelists, I'll just mention a few things which are new in these guidelines. You see, we all have been knowing about the lifestyle management, and it has not changed over so many years, last 40 or 50 years, that we have to take a proper diet, DASH diet or low-fat diet with fruit, vegetable is good. We know exercise is good. We know that we should stop alcohol, we should reduce obesity. But in this guideline which appeared last week, there's a lot of emphasis given on stress management. And I'm glad that for the first time in any guideline, the word yoga and meditation has been used. You know, stress is an important factor for causation of hypertension. It has been ignored for all these guidelines, but this guideline very clearly says that stress management is important, and meditation could be extremely helpful. So I think this is a very good take-home message. We have done also a lot of studies with yoga, that it is not only good for control of hypertension, it can control several other risk factors like obesity, diabetes, psychosocial stress, and even inflammation, etc. So I think this is a great addition. They have also used the word yoga with mild exercise. So these are, I think, two great points in this last, which has been given, the last guidelines, which has never appeared in this. So these two things really suited me very well. And of course, as Dr. Venkatram said, they have also emphasized, like other guidelines, where you should use this fixed dose combination of 2 or 3 drugs from the very start. Thank you very much, Dr. Venkatram. Now, I have 2 leading asset experts from the country as panelists. I would like their comments. Dr. Narsingham, would you like to make some comments before we ask questions from the...
Thank you, moderator, Professor Manchanda. And I think Dr. Venkateswaran has given us in an elaborate manner. He had covered not only the hypertension and its effects on vascular territories, but also had given us an information that we need to have an approach in the management of hypertension in the form of a combination therapy. What was actually depicted in older guidelines as a dual combination, now probably one has to switch over to a triple drug combination in certain situations. Not that the initial treatment should be the triple drug combination unless the patient goes for a grade 2 hypertension. For a grade 1 hypertension without a cardiovascular disease, probably the triple drug may not be really helpful. But at the stage when a patient has a cardiovascular disease with grade 1 hypertension, a triple drug probably will be able to give them a good control of blood pressure and prevent the complications. But no doubt, with respect to the grade 2 hypertension, where you need to have a combination of drugs, starting with a dual combination, probably if it suits the person who is taking care of this individual for control of hypertension, if he is comfortable with the dual therapy, he can do so. But now he has shown a lot of evidence for us to proceed further to have a good combination of 3 drugs. particularly the ARBs. He has shown a lot of evidence in the form of ARB, which has got a dual action, not only the blocking effect of angiotensin 2 receptor, but also the agonistic effect of PPR gamma, which has got a lot of advantages in improving the insulin sensitivity, reducing the insulin resistance, and improving the blood glucose levels, improving the dyslipidemia. All these parameters are probably being covered with the administration of your telmisartan, which is now considered as a metabolic sartan. And he has given an evidence to talk about the efficacy of chlorthalidone. The chlorthalidone seems to be better when compared to the conventional hydrochlorothiazide in the form of its longer duration of action, reduction of nocturnal blood pressure. In addition, it also got some pleiotropic effect, number 2. He also mentioned that in the guidelines, he wanted some information regarding the hydrochlorothiazide, which is being recommended by the International Society of Hypertension. I had gone through those information also. It is actually recommended in those countries where people cannot afford to buy or the drugs are not available. The hydrochlorothiazide probably can be a choice in lower income group of countries or low income people in whom the blood pressure control is a must. So in certain situations, it is recommended. But by and large, if you concentrate on only diuretic therapy, the preferred diuretic will be only chlorthalidone, as has been rightly pointed out. He mentioned about the beta blockers. Let me tell you that the beta blockers, the Lindholm actually published a good meta-analysis in the past, which changed the entire scenario of our approach in managing hypertension. In fact, many guys. Can you hear me?
Yes, yes.
I'm not able to see people.
You disappeared, but your voice is there, Narsingan.
Yeah, please continue.
I'm not able to see the face. Doesn't matter, no? Doesn't matter. But it's audible?
Yeah, it's
Yes,
audible.
audible.
Audible, okay. Lindholm controlling the blood pressure. This one has changed the entire scenario of approach in the management of hypertension. Many guidelines that had pushed the beta blocker as a last resort in managing hypertension. But the recent guidelines now started showing a lot of interest by reviewing the data with respect to non-atenolol beta blockers, particularly the beta-1 selective beta blockers, the cardio-selective beta blockers like your metoprolol or the corvidolol or the nebivolol or the labetalol, which is got both.
Audio is out.
Effect in not only controlling the blood pressure, but also controlling the cardiovascular risk as well as the mortality. I think Dr. Venkat has given us or shown us the way how to manage hypertension in those people in whom the blood pressure is on stage 2 hypertension or stage 2 hypertension.
Thank you very much, Dr. Rasimam. Dr. Verma would like to make some comments at this stage.
Thank you, sir.
I'm not able to hear you properly.
Congratulate Dr. Venkat Ram, our academic director, for giving this very informative talk. I will like to again say that he very well advocated the triple drug combination, and I think it's better to use triple drug combination, and when the blood pressure control is good, then we can go again to the 2-drug combination. And one thing what he mentioned, and that is very important, that we are talking more about the numbers of blood pressure numbers, but it is the blood pressure variability which is also very, very important. And while using these 3 combinations, the blood pressure variability is well addressed, because telmisartan is a long-acting sartan, so it works for all 24 hours. So the morning surge is taken care of, and most of the cerebrovascular accidents and most of the cardiac complications do occur in the morning. So this particular combination is very good. to address the 24-hour blood pressure management. Not only that, the BP load will also go down. What we have understood by carrying few studies on this ABPM, which I'm working from last 12 years. And I have also noticed that BP load is very important, how many hours the patient was suffering from the high blood pressure. And not only that, the measure hypertension, that 24-hour reading, not arithmetic mean, geometric means and time adjusted mean is very important. And this time adjusted mean is called as measure hypertension. So addressing measure hypertension is not possible by single drug. It is possible by combination of 2-3 drugs. Moreover, the drug chosen should be to address one or more than one mechanism of action. And in Indian setup, I will like to say again that in Indian setup, we Indians are having over-sympathetic drive. So beta blockers will also help in that, combating that sympathetic overdrive. So I feel that according to the guidelines again, this particular combination, triple drug combination, is useful for especially those people who are having stage 2 hypertension, and will not address only the numbers, it will also reduce complication by addressing well the variability of blood pressure, which is again very important. So the ideal drug should be that which can act on 24-hour blood pressure variability.
Thank you very much. I think you brought out a very important point that the early morning surge and the variability of blood pressure could be controlled by this. And this is also very important in the management of hypertension. Thank you very much for your observations. Now, I think we have questions from the audience.
Yes, sir.
Could we start the questions, Dr. Veena? Dr. Veena.
Sir, it was an excellent talk, especially highlighting all the recent guidelines in the management of hypertension and focusing on the combination therapy. So it was very good and very good interactions. Sir, now it is open for question and answer session. We have plenty of questions from our delegates, but let me ask a few of the questions which are relevant, sir. Many of the doctors wants to know what should be the ideal time for administration of antihypertensive, especially if it's a triple drug like this with a diuretic in that. So is it morning time or it in the late evening or night? They want to know, sir.
Dr. Venkat, I would like to.
Right. I will comment. Certainly, I would also invoke your view and that of our panelists. This always comes up when to give antihypertensive drugs. The entire evidence has been on the morning administration of antihypertensive drugs. So if you're giving drugs as a fewer pills, few drugs, then it is better to give in the morning time because that's how it was given in all clinical trials. But if the patient is on multiple drugs, 3, 4, in addition to the usual drugs like RASes, CCBs, diuretics, beta blockers, the patient is also taking a centrally acting drug such as moxonidine or clonidine and hydralazine or spironolactone, multiple drugs, then it is recommended to split the drugs in the morning and evening. What to give in the morning, what to give in the night, nobody knows. It is just a guesswork. Whatever you want to do is fine. So I think only if the patient is taking too many drugs, the nighttime administration has to be done. There are no research studies showing that nighttime administration is helpful in comparison to morning. But there is one study, by the way, in the latest issue of a journal called Blood Pressure. It's called Blood Pressure in the last 72 hours, showing that the nighttime administration is extremely beneficial in the observational trial. It is not a prospective trial. It was an observational trial in people who are taking night medication compared to take morning.
Triple combination because diuretics are there. It's a mild diuretic. You think that should be given at night or during the day?
Probably daytime because you don't want, especially elderly people, to get up in the night and then there's not light and they may fall down. So quickly, I want other to respond. Veena, I think if the patient is on too many drugs, it should be split. But if the patient is not that many medications, that like 2 or 3, probably in the morning period.
Let's
Despite,
keep it only single.
some people claiming nighttime.
If a person has triple drug only, let's say, Dr. Verma, what would you like to say?
Sir, sir, here I will very humbly like to differ. Most of the evidences what I have seen, the antihypertensive drugs should be given in the evening. Because what we have been taught in ambulatory blood pressure monitoring and also in chronobiology, it is called as chronotherapy. In chronotherapy, we advocate that antihypertensive drugs should be given in the evening. But your question regarding diuretics, especially the loop diuretics, should not be given in the evening. But you will agree that chlorothalidone, hydrochlorothiazide, and indapamide are not as diuretics. They are diuretics, but very weak diuretics. So they can be given in the evening.
But there's no study available, isn't it?
Sir, few studies are there at present. I don't remember. Few studies are there. They have compared the morning versus evening.
That is on ARBs only, ARBs and ACE inhibitors, but not really on diuretics. That's what I was saying.
Diuretics, sir, should not be given in the evening. But if combination you ask, they can be very well given in the evening. Why?
Dr. Narsingham, will you like to comment something? Dr. Narsingham, can you listen to me? Want your comment also. What time? Am I audible? Dr. Narsingham is here?
Yes, sir, you are audible.
Yes, yes. Would you like to make a brief comment? What time should it be given?
I think sir has left.
He's there, might be he's facing some internet issue. You can continue.
Okay,
with
I can go to the
panel.
next question. Go to the next question.
Sir, these days we are seeing a lot of hypertension cases in young individuals. What should be the therapy and what's the mode of management, sir?
Yes.
Sir, I'm not getting connected properly, sir. Ask these gentlemen to do something.
Okay, till you connect it, yes. Dr. Verma, what will you say in young people? What drugs should be given?
Sir, that's what I said in the beginning, that young people must receive beta blockers because a lot of sympathetic overdose is there. So that is why in China, they are using a lot of beta blockers. In India, again, despite of the not favorable comments by the various guidelines, still beta blockers are being used. So non-atenolol beta blockers can be very good choice, especially metoprolol, nebivolol. They can be given in the young hypertensives. I'm using them.
Yes, you're quite right. There's a hyperadrenergic drive in these patients, excessive catecholamines. They have tachycardia. They have slightly increased output, etc. And beta blockers may be ideal. Dr. Venkat Ram, what would you like to say? Young people.
No, I would not add anything. I think it's correct. Both of you have said that is one group where sympathetic overdrive is clearly manifest. In fact, onset of hypertension always begins with sympathetic overdrive. And with passage of time, then sympathetic overdrive gives way to other mechanisms.
But young people are scared of side effects, you see. They have read somewhere beta blockers can cause this loss of libido, etc. So what would you say that? When many patients come to me, they say, we don't want to take beta blockers. We have gone to the internet and it can cause these problems. It's called nocebo effect.
Dr. Manchanda, you know very well of beta blockers, sympathetic blockers can cause impotence or erectile dysfunction. If that is the case, then we have to change it. Either they read it or there is a fear, but when people do ask, but we cannot ask them to continue because they won't continue.
That's right.
Just for their sake, we change it. That's all.
Okay. Yes, next question. Thank you.
The next question would be, several people have asked, should ROS blockers be prescribed to hypertension and CKD stage 3, considering the hyperkalemia associated with the ROS blockades? So can this be used until what stage we can use the ROS blockers, especially the ARBs?
Dr. Venkatram, this is a very common question.
Very common question, and Subhash, you know the answer. It's a CKD and a ROS blockade is like two sides of a coin. On one hand, ROS blockers are indicated, a compelling indication for CKD. On the other hand, CKD is a potassium retaining state. Then you add pharmacological inhibition of aldosterone with ARB. So there is a risk of hyperkalemia. And how do you manage this is always a problem. And the best thing is, as long as the potassium is being monitored periodically, namely every 2 to 3 months, if the potassium is not exceeding 5, one can continue. The only difficulty, practical difficulty with this simple answer is, we don't know when the patients will come for follow-up. We hope they will come. But if they continue to take it and they don't come to follow up, then there is a high risk of hyperkalemia. And that is the reason why I always suggest, once the patient has stage 3 CKD, the best is for them to be followed by nephrologists, because nephrologists give them very strong advice, they follow them. But physicians, we tell them to come back after 2 to 3 months. If they don't come back, we're in trouble.
Yes, if they can get their potassium monitored, it could be given in serious
of course,
kidney
it's a
damage
covered
also.
indication.
CKD, yes. So it can be used if the patient's potassium can be monitored. But as you said, it's a dual weapon. One has to use it very cautiously.
Right.
Yes.
Right. Yes,
So
next,
next
please.
question would be, patient of middle-aged with no other comorbidities has been diagnosed as a hypertensive for the first time. Does the patient requires monotherapy, or if it is a combination therapy, which combination would be preferred in such type of patients, sir?
Dr. Verma?
Yes, sir. Sir, again, it will depend upon the comorbidities and the level of hypertension, second stage hypertension, of course, triple drug combination. And if the stage 1 hypertension, single drug may be enough.
Yes, I would still suggest, you see, if a person has a stage 1 hypertension less than 160/100, a 3 months intensive lifestyle management should be done first. 3 months, it doesn't really cost much. If there are no comorbidities and if it can be controlled without the medicines, I have seen many patients, it can be controlled, then there's no need of drugs. But if drugs have to be given, then Dr. Venkat Ram, would you like to give a combination of 2 small molecules, small dose of 2 drugs, or single drug, 160/100 pressure? Dr. Venkat Ram?
Ideally speaking, Subhash, I would strongly favor lifestyle changes. But then it comes to pharmacological therapy. It is your personal attitude. If you want a single drug, give it, follow the patient. If you want to give low dose combination, give it, follow it up. There is no hard rule for the degree of hypertension. It becomes a matter of clinical judgment, and we cannot enforce it that much because hypertension at least tend to be very stage 1. So if it were me, I would probably give dual drug combination, so that I don't have to see the patient very quickly.
You think there's a need for this low dose dual combination? We don't have too much in the market. That's why we have to give single drug and all. Because if there's a low dose combination available, one would like to give it possibly in stage 1 also. As you said, because the mechanism is so different, it's better to use different drugs.
Right.
So there's a need for low dose combination, we would think so.
Yes, sir.
Yeah. Okay.
So next question, rather it's a concern with few doctors. Is beta blocker and diuretic combination still one of the recommended combination, considering the high incidence of diabetes and pre-diabetes in South Asian population? What's your take on this, sir?
Yes. Dr. Verma, what would you say?
Sir, definitely diuretics and beta blockers both can aggravate the condition and can unmask the hypoglycemia. But considering that telmisartan is also there. So
I think the laptop net is okay, but I don't know, there's some connection problem.
telmisartan will take care of the diuretics and beta blockers. So I think this triple drug combination can be given in diabetic individuals as well.
Dr. Venkat Ram, what would you say?
I think
beta blockers and diuretics have been known to cause this. And there was some warning in some countries that don't use this combination.
Right. Veena, it's a good question. Diuretics and beta blockers can alter with glucose metabolism. But one thing is, all trials have shown with beta blockers and diuretics, their cardiovascular benefits are still maintained. So you maintain the cardiovascular benefits. If they develop glucose intolerance, you treat it. But glucose intolerance does not negate their beneficial effects. That is very, very important, especially in all hat, despite new onset diabetes. They are the people who benefited the most in terms of cardiovascular reduction. So the target organ protection effect supersedes the metabolic effect. So these days we don't, I won't say we don't care, but we don't consider that as a big caution the way we did 20 years ago, where we used to be afraid.
I think you're very right. The benefit outweighs its side effects, and just like statins do. Statins can also cause new onset diabetes in a small number, but I think benefits outweigh. And in antihypertensive also this is true, as Dr. Venkat Ram said, that the benefits are too many and you can use them safely. Next.
Dr.
Next
Mondal,
question.
he says that ramipril causes reduction in endothelial thickness. In addition, metoprolol also causes the same. Is there any additive effect when the metoprolol has been added to ramipril? That's what they want to know.
Metoprolol for ramipril. Dr. Venkat Ram, would you?
On endothelial function or
Endothelial.
The studies on endothelial function, because it's usually a research study, we don't study endothelial function clinically. Because these are research studies, all of them have been done with single molecules. So I can't comment on whether the combination increases the endothelial function. Potentially they could, but I will not be able to give you a solid evidence that combination is superior to monotherapy of reversing endothelial dysfunction. It could, but all the research studies are done with single molecule, not with combinations on endothelial function.
Yes, both of them decreases, so it's possible they have additive effect, just like antihypertensive effect, because they're acting by different mechanisms and all. So, but as you said, studies are not available. Thank you. Next question, please.
What should be the BP goal in ischemic and hemorrhagic stroke? Is it rational of using 10 mg cilnidipine once daily, which is a component of most of the combined pills available? In
Dr. Verma, what should be the goal in strokes and ischemic?
Sir, in acute phase, when the blood pressure is very high, the lowering should not be very fast. But the goal in stroke is almost same. It is not that the blood pressure should remain high. In acute phase, it is said that if we lower blood pressure rapidly, then it might increase the infarct size and other problems. But the goal of treatment remains same.
The goal remains the same, 130
Yes,
by 80.
Yes, sir.
Or 140 by 90. It should be preferable 130 by 80. Okay, next question,
will
please.
be preferable, sir.
It should be slowly removed. Yes.
Yeah.
Sir, what should be the dose of chlorthalidone in old patients in view of sodium and potassium levels when using the triple drug combinations?
Yes, I like to ask Dr. Venkat Ram. 6.25 is also being used these days. So what should be the dose really? Does 6.25 also act like 12.5 chlorthalidone?
Yeah, Dr. Manchanda, you have already given an answer. In elderly people, first of all, elderly defined, number one, by age. Number two, young people who have comorbidities, their cardiovascular function is same as the elderly. So there's the biological age, and then also the age as a result of an underlying disease, premature aging. 6.25, I certainly would not give more than 12.5. I would not give more than, and India is lucky that way, and I keep mentioning it because sometimes we don't recognize the pharmacological advances in India as much as we tend to embrace outside, hypertension. We have so many advances we have made. Look at, changing the topic, look at the vaccine development in India in the last 6 weeks by 6-7 laboratories, and projected completion successfully much sooner than other companies. So India has done very well in terms of this, including the low dose chlorthalidone, which is available in India. By the way, 6.25 is not available in any other country.
Good. Thank you very much. I think you are right. India has done a lot of progress. Actually, all the management of hypertension started from India. Royal Fia, you said, Rustam Jal Vakil was the first one to start that. And I can tell you, Dr. Date started this yoga studies in 1960s, 60 years back. Nobody believed it. But now everybody's accepting what he said. So I think India is doing a lot of studies, but they are not recognized that much. Thank you very much. Yes.
So there is a question, probably it's a case scenario type. Dr. Pramod Kumar wants to know. It's an elderly patient of around 80 years, male patient with the type 2 diabetes mellitus, hypertension, COPD and BPH and all. Patient is on telmisartan 80 mg, chlorthalidone 12.5 mg, silnidine 10 mg, but still the blood sugar is controlled, but there is lot of variation in the BP. And with 10 to 20 mmHg variation, will metoprolol 50 mg OD suitable, or could we add clonidine in such cases, sir?
At 80-year-old man
Yes.
with just a fluctuating blood pressure. Dr. Venkat Ram, what will be the ideal addition?
Number one, it is no matter what I say, no matter what any of us say, there is no answer to this because of the age. By the time you reach 80, fortunately, you have surpassed the national survival, which is a good thing. The question is to prevent a hip fracture. How to prevent hip fracture in this particular patient? So I don't think pharmacological manipulation will do much in this kind of a patient with rigid arteries. Only thing that occurred to me was because you mentioned the patient has BPH, perhaps removing one or two other drugs and putting him an alpha blocker as some beneficial effect on BPH. But there is no pharmacological cocktail that I could suggest in somebody with stiff arteries. I can suggest it, but on the other hand, we don't have any solid evidence. We just have to make sure that the patient does not fall down when they stand, which could be a problem with an alpha blocker, by the way. That could be a problem because the greatest problem in that age group is a fracture of the hip. And once they have the fracture of the hip, that is almost like signing a death certificate with pulmonary embolism, etc. So I don't have any honorable answer other than hoping that the patient will not develop a hip fracture.
And there are very few studies, I agree with you, above 80 years of old. But if you are aware of that Hyatt study in which they had used perindopril and a small dose of indapamide, they had shown a mortality benefit also, if I remember correctly. Right. That was above 80 years, that Hyatt trial or perindopril trial in elderly above the age of 80.
Right.
So that could be tried because that's the only evidence base we have above 80. There are very few studies. You agree with that study, right, which is called Hyatt, HYUT? Yeah. Thank you very much. Next.
Sir, 2-3 doctors have asked this question. Use of metoprolol in diabetes, is it safe? Alone or in combination? Because maybe there may be masking of hypoglycemic events. Is this the concern they want to know, sir?
No, I don't think it's a concern. I can answer that. If a patient of diabetes has angina, for example, or heart failure, we will definitely give beta blockers. And that's not a cause of concern at all. And this so-called the hypoglycemia masking is really not that clinically that much. So any patient of diabetes really should not be excluded from the metoprolol therapy also.
And now it is audible for me. I can join. Yeah.
Yes, you could join. Okay, we'll push the next question to Dr. Narasimhan. Okay. Could you give us the next question?
What is the new definition of isolated systolic hypertension? Has it been changed?
The new definition is systolic blood pressure more than 140 and diastolic blood pressure is less than 90. That is a recommendation that has been given now in the ISH guidelines. Previously, we were all under the impression that 160 over 90. Then it was brought down to 140 over 90. 140 to 159, we call that as the grade 1 isolated systolic hypertension. Anything above 160, it was called as a grade 2 systolic hypertension. So 140 and above systolic, the diastolic is less than 90. You should consider that as an isolated systolic hypertension if it is occurring even in younger individuals or adolescents or even elderly people also. The same criteria holds good. Yes, sir.
I think before we ask next question, I like to ask one question to Dr. Venkat Ram. You know, yes, we are going through this pandemic of COVID, and COVID-19 and hypertension have been somehow related. Could you tell us about how hypertension, which is a very frequent comorbidity, and hypertension are associated, and especially the role of ACE2 inhibitors, which are there in COVID and all? Because this hypertension is talked quite a lot in this present pandemic, which is really bothering all of us. Dr. Venkat Ram, would you like to say something about that? The relation of hypertension with COVID?
Right. It's it's needless to say, it's a very timely question. All the earlier studies from China have shown that people who have history of hypertension had higher complication rate from COVID. And the mortality from COVID was highest in people who had hypertension, 33%, diabetes, 28%. So the highest mortality from ARDS in COVID was in people who have history of hypertension and diabetes. The problem with this study is that they have hypertension by history, but not known what was the level of blood pressure when they came in, because these patients are very sick. And most of them don't bring any records because they're very, very sick. High blood pressure by itself is not a predisposing factor to COVID. But high blood pressure uncontrolled is a predisposing factor to the complications of COVID, which means it is all the more important to control the blood pressure in the community. All the more important, because uncontrolled hypertension increases the complication rate from COVID, namely ARDS. Why is that? It appears to be, as is well known, this happened also in SARS and in MERS. When people have uncontrolled hypertension and they have acute lung injury, there is no cardiovascular response they can mount. They already have LVH, they already have coronary artery disease, they already have microcirculatory problems, so they cannot mount compensatory response. So acute lung injury is absolutely devastating on cardiovascular function, and they cannot compensate for acute lung injury if they have chronic hypertension or any other cardiovascular risk factor. So one thing is very, very clear. Hypertension does not predispose you to develop COVID, but uncontrolled hypertension predisposes you to cardiovascular complications from COVID as a result of ARDS. That is clear. Now, the other thing is the ACE2 levels which go up mainly with ARBs and ACE inhibitors. When the ACE2 level goes up, ACE2 is the same enzyme that promotes the entry of the virus into the cell. So it has been suggested that increased ACE2 can cause increased viral load in the lung, and therefore these patients might develop ARDS much more than people who are not on RAS blockers. And that is a theoretical consideration from animal models. But clinically, it has not been proven. For example, last week, there are a series of articles in New England Journal of Medicine, especially one from Italy, which is worth looking at it. Because Italians have all the data. Italian health system, unlike Indian health system, their records are all maintained by the government. So anytime patient takes a medication, it is registered in the government data. So they know how many patients were taking RAS blockers, how many patients were taking other drugs, and who developed COVID, and who developed COVID complications. The COVID complication rate was very similar in patients who were taking CCBs or beta blockers or diuretics or RAS blockers in these 18,000 patients. So it did not make any difference in terms of outcome in patients taking antihypertensive drugs. So this is from the Italian data. But paradoxically, the data have come, it is very strange that Italian experience is now converted to, sadly, to a country that you never imagined, US. Experiencing, I never thought, even in my dreams, that US will become such a center for complications from COVID, which I thought they would have learned from China and from Italy. But having said that, the experience from US, now, number of papers have been published now, that there appears to be actually a protective effect of RAS blockers for recovery from complications of COVID. And in fact, there is a paper that came 2 days back, whether ARBs should be given as a preemptively to patients in community to prevent COVID complications. So it looks like the ACE2 increase because it causes an increase in Ang1 to 7, causes vasodilation, may be actually protective. So, Mr. Chairman, I don't have any single answer, but the points are for the lay community that hypertension does not predispose you to COVID, but uncontrolled hypertension causes cardiovascular complications in COVID patients. So it is all the more important, Narsingan, who was the reviewer for the guidelines, it is all the more important to follow the guidelines and to control hypertension in general. And one of the benefits could be reducing the COVID complications.
Yeah, and one should continue ARBs, you see.
Oh, continuation of ARB. Yeah, I would not go to this extreme extent suggested by a couple. I will send you this paper after we conclude this call.
Because this is a study started of beneficial effects of losartan in COVID cases. And there's a study of recombinant angiotensin, ACE2 also, for decreasing this.
Right.
Because angiotensin 2 can increase the damage to the lungs, etc. So I think very interesting because these are really related now very well. Yes, Dr. Narasimhan, would you like to say something about COVID?
I think everything was covered by Dr. Venkat. I think the data is has been collected and is published also. And people who have been started on ARBs or ACE inhibitors for the control of hypertension need not stop when the blood pressure is under good control during the time when they enter into the ICU with a COVID problem. They should continue to take it. There's no point in stopping it. A new patient in whom the blood pressure is slightly on the higher side, the question is to start it or not. That has to be taken as a good decision by the healthcare provider. He may introduce an ARB, which is a smaller dose, which might probably help in this current scenario when we think about the ACE2, which is beneficial and is increasing the levels of 1 to 7 of the angiotensin 2, which is beneficial, which has got a vasodilatory capacity. With that in mind only, we need to probably advise those patients to start on ARB when they have a slightly elevated blood pressure during the time of entry into ICU. But most of the patients, when they develop complications, the blood pressure is surprisingly normal or they go for hypotension. I don't think a vigorous or an aggressive treatment with antihypertensive drugs are required at the time when the patient is in ICU. So people who are taking ACI or ARB should continue to take it to prevent the complications of hypertension-related cardiovascular complications during the time when they have this virus.
Thank you very much. I asked this question because this is being now written quite a lot in this COVID. Yes, any other questions we have?
Yes, sir. So this is a question to Dr. Venkat Raman. So you did mention in your presentation about the central aortic blood pressure and its role in reducing the mortality as well as morbidity. What would be the role of beta blockers, or beta blockers should be considered in such patients?
Right. First of all, reducing central aortic blood pressure theoretically is helpful because you're reducing the blood pressure that is felt by the organs. But no study has shown central aortic blood pressure is a target for the treatment. It's always the peripheral blood pressure. So we continue to use the peripheral blood pressure, but if it reduces the central aortic blood pressure, it is an added benefit. But central aortic blood pressure is not a target for any antihypertensive drugs, even now. Although they are readily available, even now it is not. I just have one comment I want to make because our chairman is a pakka quintessential Delhi Babu. And because he's a Delhi Babu, I have a Delhi-centric question.
Yes.
I have been trying to get from ICMR or from Department of Health and Family Welfare whether we have any data among Indian corona positive or COVID patients, any data in India on what their intake of previous drug therapy is, such as antihypertensive drugs. According to the central government, it is up to the state government to have. And I call the state government here in Telangana, they said those data cannot be released. They won't tell about history of hypertension or diabetes or anything, at least in Telangana. they said those data cannot be released. But it will be important, I think, not for my interest. It is very important for India as such a big country to know what are the antecedent comorbidities these patients had who either developed COVID illness or they develop ARDS. I think for public health, it's very, very important to know. In fact, this is what happened in Italy also. In Italy also, the principal author told me that they would not release the data, but they almost went to the court to get the data. And because of the threat of a legal thing, they released the data. But I'm not suggesting we should go to RTI or anything, don't get me wrong. But I think at least since you're a Delhi-centric person, there should be some effort to know the comorbidities among our patients who develop COVID or ARDS and what drugs they were taking. We don't even know if they're compliant, by the way. But the patients are given the drugs. Even in Italy, we only know those patients fill the prescription. We don't know if they took it. That is the problem. So
no, actually, I also am not aware of any data which is published, but I am aware that there are large number of trials which have been taken by ICMR, All India Institute. They're trying to collect all this data, clinical as well as in some interventions they are also doing with even herbal drugs, Ayurvedic drugs, etc. So number of projects are there. The data is still not out, but I'm sure that it will eventually come out because they are doing large number of studies with this. And they are taking states also into confidence. And so I think the data is not available, but I'm sure it will come in our country. Because people are younger here, I won't think hypertension will be that common as in the Italian. Because the people who died in Italy were 80 years and above. Right. And 76% of those who died, they had hypertension. But that is the normal incidence of hypertension at that age. Right. At 80 years, 76% is not much. Right. So, I do not have any data as yet, but I am sure that data will come out because large number of projects. I was in a meeting and there's some 20 projects on COVID are going on with all ministries and so on and so forth. Then I'm sure it'll come. And if I get it something, I'll let you know. I'll try to get from ICMR sources. Yes, any other question? I think how much time we have got?
So I think many doctors are wanted to know what's any recent advances in the management of resistant hypertension and the role of spironolactone and other aldosterone antagonists.
Dr. Narsingham?
The resistant hypertension is a condition when you had given 3 drugs, including a diuretic, and the blood pressure is still 140/90. You probably consider that as resistant hypertension, provided the patient's adherence is good, compliance has been excellent, he has not been using any other concomitant therapies like NSAID administration or any other drugs which can probably increase the blood pressure. If all these things are ruled out and the other secondary causes are also ruled out by clinical examination and with the available data, then you think that it is a patient with a problem of the resistant hypertension. When you see a patient with resistant hypertension, you have already exhausted 3 drugs. That means you need to add 1 more drug, which will probably help these patients to bring down the blood pressure. The drug that should be administered at that stage is a spironolactone, such an aldosterone antagonist. This drug is a wonderful drug, which can be started with a dosage of 25 milligram, can go up to 50 milligram, and can go up to 100 milligrams, so depending on the patient's condition and the concomitant therapy. The only problem with the spironolactone is that it can elevate the potassium levels. So you need to be very careful in analyzing the electrolytes repeatedly so that you can update the dose. So starting with the 25 milligram, go up to 50 milligram, go up to 100 milligrams. But the studies available using the spironolactone in the management of hypertension are not that much available. The only thing is there's been tried in people with heart failure, has shown an enormous amount of benefit. So it is taken for granted that it is also a good drug which can produce a good amount of benefit even for patients with hypertension. So the spironolactone is the one drug that should be added along with the other 3 drugs in the management of resistant hypertension.
And what is, I think, worth investigating a research is the effect of yoga and meditation. A couple of patients of mine, I have tried that yoga meditation and resistant hypertension did come down. So I think this needs further research. But as you said, we have to add drugs like spironolactone and be sure that the patients are taking the drugs properly. Thank you very much. Any other questions? I think
it's the last question. Patient with a stage 2 hypertension and the ventricular hypertrophy, what would be the preferred drug or combination? And also if the patient has type 2 diabetes mellitus.
Dr. Verma is there? Dr. Narasimhan, you continue. Yes.
Yeah. The thing is, left ventricular hypertrophy is one important parameter which one has to keep in mind for as a predictor for our ongoing left ventricular failure and ongoing target organ damage, including the kidney disease, or even patients will be pushed for an atherosclerotic cardiovascular events like coronary artery disease or stroke events. So one should be very careful in reducing the left ventricular hypertrophy. It has been identified in the beginning of treatment, either with the ECG or with the echocardiography. Echocardiography is more sensitive than the electrocardiogram. If a left ventricular hypertrophy as a baseline, if it is very high, and the left ventricular mass index is also high, and you are starting some drug, the best drug that can be used is an ARB. Trials have shown that ARB is the best drug, the number one. Number two, the other drug that can reduce the left ventricular hypertrophy is a diuretic. The third one is a calcium channel blocker. And the fourth one is the beta blocker. I think Dr. Venkat probably will top it up if anything else that has to be added.
No.
No,
Important
that's
thing
all
is
right.
blood pressure control, and
Yes.
Dr. Narasimhan has shown some pathways of blood pressure control, but LVH is a blood pressure driven phenomenon. It's a hemodynamic abnormality, and you reverse the hemodynamics, namely reducing the BP or fixing the aortic valve if the patient has valvular disease.
Yes.
One thing that I should emphasize during your talk also, you mentioned one important message through value study. People who received the combination of amlodipine plus a diuretic have shown enormous amount of benefit in the form of reduction of blood pressure, resulting in reducing the cardiovascular events, including stroke, heart failure admissions. All those things have come down in those group of people who reach the levels of blood pressure goal within 6 months of starting the treatment. That emphasizes and re-emphasizes that if you are starting treatment, the patients need to reach the goal as early as possible, not more than 6 months. You need to bring it down to the levels of goal or what you are achieving in these patients with these combination of drugs. That's the most important message that I thought I should probably emphasize.
Thank you very much. Do you have any other? Otherwise, you like to
Sir,
wind
I
up now.
think we are done with the question answer sessions. It was an excellent interactive session, truly. On the behalf of Ajanta, I once again thank Dr. Venkatraman for his wonderful talk and help us to conduct this webinar. I also thank Dr. Manchanda for chairing the session and the panelists, Dr. Narsingan and Dr. Narsing Verma, for their valuable inputs, which is much needed. I thank all the delegates who have joined us, and sure there was a tremendous value add in this session. I thank Mr. Suresh Pandey, the entire HO team and our field force to make this program a success. And all of you, because all of you are like in the front line, war on the COVID-19, the war between the COVID-19, I would request all of you to stay safe and stay healthy. Thank you again. Thanks one and all. Thank you, sir.
I also like to thank Ajanta Pharmaceuticals for sponsoring this beautiful program, which I think will be extremely useful to all the physicians. Especially like to thank Mr. Suresh Pandey, whom I know for last about 50 years. In 1972, he was a research assistant in All India Institute when I was the professor there. So Mr. Pandey, thank you very much. And Ajanta Pharmaceutical, thank you very much. Thank Dr. Venkatram and both the panelists. They have done an extremely good job, and I am sure this will be of great use to the practicing physicians. Thank you very much.
Let me take the opportunity. Let me take this opportunity to thank Dr. Venkat, Dr. Manchanda, and my friend Dr. Narsing Verma, and of course Suresh Pandey of Ajanta Pharmaceuticals and other organizers for giving me this opportunity to be with the eminent people in cardiology as well as in hypertension. Thank you.